ma'am.
Okay, Karthik, start.
Miss Sridivya, a 28 years old female, hailing from Puliyandopu, housewife by occupation, belonging to socio-economic class of class 3, with obstetric score of Gravida 2, Para 1, Type 1. She is booked and immunized at Puliyandopu PHC with the last menstrual period of Jan 21, 2020, and the expected date of delivery is at 28th October 2020, with the gestational age of about 32 weeks. Coming to chief complaints, she presented to the OPD with 8 months of amenorrhea with referral from Puliyandopu PHC for evaluation and management of raised blood sugar levels. History of presenting illness, she was diagnosed with gestational diabetes mellitus at 6th month of pregnancy, and she is under meal plan. After that, she is now under treatment insulin. With the history of raised blood sugar level, with the 2-hour postprandial being 190 mg per deciliter detected during the routine follow-up. She is under insulin therapy for 1 month, which is irregularly followed. History of perception of fetal movements, no history of increased frequency of urination, burning, micturition, pain during micturition, no itching, no history of vaginal discharge, no history of excessive weight gain. All 3 trimester scans were done and told to be normal.
Okay. Sorry, can we just go back a little? Yeah. So 8 months of amenorrhea, she was referred as like raised sugars. So for further management. Okay. Next slide, please. So at 6 months, she underwent screening. Okay, chalo. You continue. We'll ask the questions later.
Okay. History of present pregnancy. She was conceived spontaneously after marriage with a spacing of 3 years after the first child. First trimester history, which was confirmed by urine pregnancy test at 6th week. History of nausea and vomiting for 2 months. No history of hyperemesis gravidarum. No history of fever with rash. No history of bleeding PV and abdominal pain. No history of burning micturition. No history of chronic drug intake. No history of irradiation. Dating scan was done at 8th week and told to be normal. OGCT was done and told to be normal. Second trimester history, quickening felt at 5th month. History of iron and folic acid intake. Deworming is done. 2 doses of TD was given, and OGCT according to DIPSI criteria was done and found to be abnormal at 6th month, and she was diagnosed with gestational diabetes mellitus and was advised to have a diet plan and further treatment with insulin. No history of bleeding PV or draining PV. No history of abdominal pain. Anomaly scan was done and told to be normal. Fetal echo was done at 6th week. Third trimester history. Perception of fetal movements are present. No history of edema. No history of bleeding PV. No history of abdominal pain. Blood sugar level testing was done and found to be elevated, which she was referred to Gkmc. No history of persistent headache, nausea, vomiting, epigastric pain, and blurring of vision. Growth scan was done and told to be normal.
Okay, wait a minute. So why have you asked for all these blurring of vision and other things? Third trimester history.
If these are signs of imminent eclampsia, ma'am. If she has diabetes associated vasculopathy or due to diabetes, there will be large placenta, ma'am. So she is exposed to more chorionic villi, which may cause PIH.
Yeah. We don't call it pre-IH anymore. We call it preeclampsia. So she can be, see, all your GDM, they have a risk factor to become preeclampsia. So if there is preeclampsia, so these should be coming in your history, whether they have any imminent signs of eclampsia. Okay, so for those things you asked. Why have you asked for any history of burning, micturition, abdominal pain, and all those things?
Ma'am, burning, micturition, and because of increased risk of UTI and asymptomatic bacteria, ma'am. Because there is
asymptomatic bacteria will be like, asymptomatic only. You're going to diagnose by a routine culture which you do. Okay, so when you do a urine test, you do a culture, there will be bacteria in the urine, but the patient will be totally asymptomatic. So it is like, goes by the name. So you can have symptomatic UTI itself. And especially when the sugar is not in control, they are prone to any infections. Okay, so what are all the common infections they will come across? One is UTI. What else?
Candidial infection, moniliasis.
Candidial. So moniliasis. So that is why you are asking for white discharge. You can even be specific to ask whether you have curdy white discharge, itching with white discharge. Then it is significantly, you can say that it is because of candidiasis. These two history has to be there in your negative history, that it is not there. Okay. What other infection she can have? What other infection do you think she can have? Let alone pregnancy. After that?
Puerperal sepsis.
Yes, she can have puerperal sepsis. She can have wound infections. Your LSCS wound itself cannot heal.
Okay.
Okay, so all those things you should remember.
Okay.
Okay, go ahead, doctor. Go ahead.
Menstrual history, age at menarche is 13 years, and which is regular cycle. 30-day cycle of 4 is menstruation and a normal flow, no history of passing of clots, no history of pain during menstruation. Marital history, age at marriage is 23 years, duration of marriage is 5 years, is non-consanguineous marriage, no history of contraceptive use. Past obstetric history, she was conceived spontaneously after 6 months of marriage, no history of gestational diabetes mellitus or gestational hypertension in the previous pregnancy. All 3 trimesters were uneventful, normal vaginal delivery with single live female fetus of 3.2 kg and it's live and healthy. Postpartum period was uneventful.
Okay, so let us wait a little bit here. Okay, in the previous pregnancy, imagine your patient is a over diabetes. Okay, so let us imagine that. Okay, she's not a GDM now; she's a over diabetes. So what all in the previous history will give you that she can be diabetic already in the past obstetric history?
Previous history of GDM.
Yes. Then?
Previous history of any congenital abnormalities in fetus.
Yes.
Previous history of any IUDs or stillbirth or more than 3 abortions.
Yes. Recurrent pregnancy loss. Also, you should think of GDM. So, any history of GDM. What else?
Previous history of polyhydramnios or big babies, macrosomes.
Yes. Previous history of macrosomias. So, all those things has to be come in your past obstetric history. Whether she had abortions, whether she had many abortions, whether any unexplained IUD, whether there was anomalous baby, and macrosomia or polyhydramnias. And even you can ask your recurrent UTIs, candidiasis, and all those things can also be included. Okay, we'll go next.
Baby cried immediately after birth. No history of NICU admission. Breastfeeding initiated immediately after birth and breastfed for 2.5 years. Postnatal period was uneventful. Past medical history.
Yes, yes, go.
Past medical history, no history of diabetes mellitus, hypertension, bronchial asthma, epilepsy, TB, thyroid, and cardiac diseases. No history of blood transfusion, no history of drug allergy. Treatment history, she was under insulin for 1 month. No other chronic drug intake. Personal history, patient is on a diabetic diet. For breakfast, she took 3 idlis, around 11 a.m., 1 glass of milk, and lunch, 1 cup rice with green leafy vegetables around 5 p.m., 1 glass tea with 2 biscuits, and dinner 2 chapatis. Normal bowel and bladder habits. Sleep is adequate. No history of drug abuse or smoking or alcohol. No history of passive smoking. Family history, no history of diabetes mellitus and other chronic illness in her family. General examination. After getting consent from the patient, examination was done. She was moderately built and nourished. No pallor, icterus, no cyanosis, no cupping, no pedal edema, no generalized lymphadenopathy. Anthropometry, her pre-pregnancy weight is about 70 kg and her height is 160 centimeter and her BMI found to be 27, which is overweight, and a present pregnancy weight 78 kg. Weight gained is 8 kg, which is normal. Vitals, pulse rate 82 beats per minute, respiratory rate is of 16 per minute, BP is 120 by 80, measured in right upper arm in sitting position, afebrile. Examination of breast, thyroid, and spine are found to be normal. Examination of abdomen, consent is obtained from the patient. Patient is asked to empty the bladder and she is examined in supine position with the thighs semi-flexed. Abdomen is exposed from Ziffy sternum to pubic symphysis. On inspection, abdomen is elongated longitudinally. Umbilicus is everted in the midline. All quadrants move equally with respiration. Linea nigra is extending from pubic symphysis to umbilicus to pubic symphysis. And stria gravidarum is seen. No scars or sinuses or dilated veins are seen. And palpation, after correcting dextrorotation, palpation is done. Her fundal height corresponds to 32 weeks of gestation. Symphysia fundal height is 32 centimeter. Fundal grip, which is soft, and it is found. Fundal grip, soft, broad, and non-independently bilateral fetal parts, probably buttock region is there. Umbilical grip, uniform Smooth, curved, hard resistance is felt on the left side, suggestive of spine, and multiple irregular small nodules are right side, which is limb buds, and first pelvic grip. Hard, round, independently palatable mass is present, probably head, so it is cephalic presentation.
Okay. So what is one thing which is missing in your examination, which I will be really happy if you tell me?
Abdominal grip.
Okay, what else? She is an uncontrolled diabetes.
Fetal weight.
Yeah. One more. One is macrosomia. One more complication is?
Polyhydramnios.
Yes. So there should be something mentioned that clinically liquor appears adequate, normal, something like that should be there. No. Okay. It should be there in your examination. At least we know that there is no polyhydramnios. See, okay, now I'm telling you, your patient does not have polyhydramnios. Tell me why.
Huh?
With your examination finding, I am telling you, your patient does not have polyhydramnios. So tell me how.
Ma'am, fundal height is not more than the period of gestation.
Excellent. So when your fundal height is more than the period of gestation only, you're going to think of polyhydramnios or your macrosomia. So when the fundal height is corresponding, we indirectly implies that the growth is appropriate for gestational age. So there is no much of polyhydramnios or macrosomia. Okay, go ahead, doctor. Very good.
Rahul Fexley. Auscultation, fetal heart sound was heard below the umbilicus at the left spino-umbilical line, and fetal heart rate is found to be 140 beats per minute. CVS examination, S1 heard, S2 heard, and no murmur. RS examination, no no vesicular blood sounds are heard, no added sound. CNS examination, no focal neurological deficit. Summary: Miss Sridivya, 28-year-old female with a gravida 2 para 1 live 1, admitted at 32 weeks of gestation with the last menstrual period of January 21, 2020, and expected date of delivery at October 28, 2020. It is a known case of gestational diabetes mellitus for the past 2 months, referred with raised blood sugar level for evaluation and treatment, and she was under meal plan and irregular treatment with insulin for a month. She has a single live fetus with cephalic presentation with a good heart rate.
Okay.
Diagnosis: a 28-year-old female, Ms. Sridivya, gravida 2 para 1, came with 32 weeks of gestation, is diagnosed to have gestational diabetes mellitus, complicating pregnancy, has a single live fetus and cephalic presentation with a good fetal heart rate of 140 beats per minute.
Okay. So what is gestational diabetes mellitus? How do you define?
It is a carbohydrate intolerance of variable severity with the onset or a first recognition during the present pregnancy.
Okay. So what is your, what is these two differ? Either onset or first recognized. What is the meaning of that? Abdina enna? So it means it can be a pre-gestational diabetes also. Even if you diagnose a diabetes mellitus first time in pregnancy, you call it GDM for all practical purposes. Okay, ma? So
Okay,
that's why either it can be onset in pregnancy, which is the actual GDM, or you have not diagnosed throughout, and only in pregnancy you have done a blood test and diagnose also. You will call her GDM only.
Okay.
So you will not take her as type 2. Okay. So what are all the risk factors for GDM?
Ma'am, previous history of GDM.
Previous history of GDM, yes.
Family history of diabetes.
In the?
In first degree relatives.
Yes, excellent. In first degree relatives, yes.
Age more than 30.
Yes.
Obesity.
Age. Yes. BMI more than?
30.
Yes. What else?
Previous history of congenital malformation babies.
Yes. Congenital anomalies. Same thing. Your IUDs, stillborns, your this one's, what is that? Your recurrent pregnancy loss. And what else? Macrosomias, polyhydramnios, everything forms the risk factors for GDM in the current pregnancy. Okay, fine. Okay. In your current pregnancy, there are certain things when we think that, okay, she can be diabetic. What are all there? Current pregnancy risk factors. A pregnant patient coming, okay, she's coming to you for checkup, and you think, no, she can be GDM. I want to check the sugars again. So what are all those factors?
UTI.
Yes, UTI. Then, especially when it is recurrent. First episode of UTI, you will not think, but recurrent episodes of UTI, you're going to think. Yes. What else? Polyhydramnios, excellent. Yes.
Macrosomia.
Macrosomia, excellent. And one more.
Monilial infection.
Monilial infection, candidiasis. So in current pregnancy, if your patient has recurrent UTI, recurrent candidial infections, and macrosomia and hydramnias, then you're going to go and check, okay, check your sugars. Okay, there is one investigation. When you do, you think that, okay, no, this patient can be diabetic. Urine routine. Okay, what is the significance of here? What is glycosuria?
Ma'am, in pregnancy, the renal threshold is lowered, ma'am. So
Excellent.
even in normal amount of glucose in plasma, it get excreted through urine.
Yes, that is what is the previous teaching. Okay. Okay. So the normal glycemic threshold was 180. Okay. In a normal patient. Abdina enartho, when the blood sugar reaches 180, you will get sugar in the urine. Clear?
Okay.
That is glycemic threshold. Abdi glycosuria threshold. So எந்த அளவுக்கு blood sugar போனா யூரின்ல வரும் அப்படின்னு. So ஆனா pregnancy-ல the threshold is lowered. அப்படின்னா என்ன அர்த்தம்? Even at 140, the patient can have a glycosuria.
Yes.
Okay. But it has been found that even a random sugar of 140 in pregnancy is GDM. Okay. So now we give importance to glycosuria. So even a patient who has persistent glycosuria, then you again go and check her with either a GCT or a GTT to rule out GDM. Okay.
Okay.
Though we know that glycemic threshold is lowered, it is still 140. It takes for the urine to have glucose. And any random sugar of 140 in pregnancy is high. So that is also significant. Okay, fine. So why pregnancy is a diabetogenic state? Why does these pregnant become diabetic in pregnancy?
Ma'am, placenta will secrete human placental lactogen, ma'am.
Okay.
Which antagonizes the action of insulin, ma'am.
Okay. So these, yeah, the insulin resistance increases. So there are many hormones, not only your HPL, there are many other hormones, estrogen, progesterone, your cortisol, everything. So all the hormones, they all increases the insulin resistance. That is one. What are the other reason?
Placenta secrete, it secretes insulinase enzyme, ma'am, which causes degradation.
The placenta secretes insulinase. So thereby it causes your insulin to be reduced, or it is, broken down by the placenta. So that's why your pregnancy itself is a diabetogenic state. Okay. So what are all the screening tests we do?
Ma'am, according to WHO, we do only diagnostic test, ma'am, no screening test only. But ACOG recommends two-step approach. This is a screening test and diagnostic test should be done. On screening.
Yes, you go ahead. We'll finish then.
On screening, we are giving a OGCT, ma'am, where no fasting is required. 50 grams of glucose should be taken by the patient, and after 1 hour, you are checking for a 1 hour postprandial blood sugar, ma'am. If it is less than 140, it is considered to be normal. 140 to 180, you want to do diagnostic test, and more than 180, it is diabetic. For diagnostic test, we are doing.
Okay, so fine. You have any more slides in your this one?
No.
Let us finish your thing. That's no investigations. And what else do you have? We will talk on all these things. Treatment. Let us talk a little bit. Yeah. So now let us. You can stop sharing so that I can get a whiteboard. Is it okay with all of you? Yep. Okay. So you should know about screening test. Okay. So one is what your AIC, like your ACOG, American College of Gynecology, Obgyn Gyn, okay, what they say, okay, they are the only people who follow two-step approach, which you recently explained, okay. One step, the first step is OGCT. OGCT, where you give 50 grams of glucose irrespective of the previous meal, and then we keep a cutoff of 140. Some people even keep a cutoff of 130. Okay, routinely 140 is what is taken, and then if the 140 cutoff they go, then you go for it to second step, and the second step is OGTT, where you give 75 grams of glucose, and then you have a cutoff to diagnose this. Okay, this is what your ACOG recommends. But we in India, we all follow DIPSI. Okay, so DIPSI is done as universal screening. So don't say we don't have screening at all. This is universal screening we follow in our country, because we fall under the category of moderate risk group or even the high risk group for diabetic, because we have a ethnicity. The Asian ethnicity is very high risk for getting diabetes. Okay, so we have a universal screening. What does universal screening means? Screening all the pregnant women. So if you see in all the antenatal checkups, someday or some point of time they will be screened. Okay, so we do universal screening. So what is DIPSI? Same as your OGCT, irrespective of your previous meal. So irrespective of meal, okay, ideally the patient in the first visit, okay, or when the vomiting is subside, depending on the consultant, we give that. We give this patient 75 grams of glucose, and a single test of 2 hours sugar is taken, and the same cutoff of 140 is used to diagnose GDM. If it is more than 140, we give it as GDM. If it is 120 to 140, we tell it as impaired glucose tolerance. And if it is more than 200, it is diabetes mellitus. Okay, this is what your DIPSI test is. Some of your examiners prefer to call it DIPSI as OGCT. Okay, but ideally your DIPSI is OGTT. It is like found that your DIPSI is equivalent to a GTT, but only a single 2-hour test is done. Okay, so whatever your professors are saying, you can just follow that. If they call it OGCT, you follow that. If your professor says GTT, you can do that. But otherwise, you can just keep it as DIPSI. Okay, so two-step approach, which is followed by the American College, is your OGCT with 50 grams, followed by OGTT. And this OGTT consists of a fasting, 1 hour, and a 2 hour. Okay, they do 3 tests. And when 2 tests is more than 2 is more than the borderline, then we call them as diabetic. Okay, so there are like a lot of OGTTs available to interpret values. So have you heard of all these things? One we have already told about DIPSI, so which is 2 hours, 140. Okay, what are other things? Have you ever heard? Excellent, doctor. Carpenter-Cousins technique. And one more is?
National Diabetic Data Group.
NDDG, National Diabetic Data Group. We don't follow any of these nowadays. So it is okay that if you don't know the cutoff for these things, because these are not followed, now we go with the WHO's GTT, which is fasting of 92, 1 hour of 180, and 2 hours of 153. This is the WHO's GTT guidelines. Okay. So NDDG was the highest values which they had for cutoff. It was like 105, 190, 165, and 155. This was the cutoff for NDDG. Then Carpenter-Cousins was a little bit less, 95, 180, okay, 155, and 140. Even if you can't remember these things, it's okay, because these are not followed nowadays. If you want to remember few values, you please remember only these.
Okay.
92, 180, 153, which is your WHO's OGTT. Okay.
Okay.
Or you can even say DIPSI is what is universally followed. Even if you say DIPSI, you're not wrong. Okay. So with that, let us go. So we do universal screening. And when is the screening usually done?
24 to 28 weeks.
Yes. So depending if your patient has risk factors. We spoke about the risk factors now. So if your patient is already obese, she's more than 30 years, she has a family history. So you cannot wait till 24 weeks till she becomes an over diabetic, right?
Yes.
So for her, it is first visit. Whenever she comes to us. Okay. When they don't have risk factors, then you do it at 24 weeks.
Okay.
And in first visit, if it is normal and still she has risk factors, then you repeat for this patient between 28 and then 32 weeks, depending on how much the risk factor is. Okay, so if your patient is an obese patient, she's elderly and obese, she has some hypertension and also family history, then you're going to do it at least 3 times.
Okay.
Okay, so these things you should remember. And what is the diagnostic test is always OGTT. So that we have already told you. Cutoff, you remember the WHO's cutoff. Okay, what is the cutoff to diagnose diabetes? Cutoff to say yes, she's diabetic.
2 hour postprandial.
1 hour fasting and postprandial.
Fasting, if it is
Same as non-pregnant, very different. Non-pregnant diabetes diagnosis. Fasting of more than 126. Postprandial of 200.
Okay.
Okay, so that is for your diabetes diagnosis. Okay, so what is the importance of HbA1c?
It reflects the glucose level
Glycemic control
of
over
past 3 months. Past 3
yes,
months.
it gives the glycemic control for 3 months. Why in pregnancy it's not a very good test in pregnancy?
Ma'am, we are suppose the female comes late during pregnancy, like in a second trimester and third trimester. Actually, HbA1c is mainly for congenital malformations detection. If it is
okay. What else? See, imagine a pregnancy where HB is low.
okay.
Okay, your HbA1c will also be falsely low, right? So pregnancy, we know it is hemodilution. Sometimes they can become anemic. When your hemoglobin itself is low, sometimes HbA1c can be falsely low. So that is why we don't routinely do HbA1c for all patients. So only when you have a doubt that she can be a over diabetic, then you do it in the first trimester. Okay. So what is the ideal level of control which you expect in pregnancy?
Less than 6.5.
That is HbA1c raise. Fasting postprandial ideal control.
Fasting of less than 95.
Yes.
And 2 hour postprandial of less than 120. 1 hour less than 140.
Very good. Okay, so this you should remember. Even if somebody wakes you in the night and asks you what is the ideal control, then you should get up and say, yes, these are my ideal controls. Okay, so this you should not forget.
Okay.
Okay, so what are all the effects of diabetes on the mother? The sense, what are all the complications the mother can have?
Increased risk of infections, ma'am. Like
okay.
And
yes.
There will be placentalomegaly, ma'am. So there will be
preeclampsia.
Preeclampsia and placenta previous because of large
very
placenta.
Rare. Very rare. Let us not talk about very rare things. Yes, polyhydramnios, macrosomia baby. So imagine a macrosomia baby is delivering normally. So what will happen?
Increased incidence of instrumental delivery, cesarean
Yes.
sections.
Cesarean sections, instrumental delivery, and further, what else can the mother, like perineal tears, 3rd and 4th degree perineal tear, PPH because of your polyhydramnios. So all these things, and maybe over distension, difficulty breathing, those are the rare things. Okay, so these are all the problems on the mother. What are all the problems on the fetus?
There will be fetal hyperglycemia, ma'am.
Okay.
Because of maternal hyperglycemia, which may lead to macrosomia.
Okay. Why macrosomia?
Increased level of glucose in fetus may cause increased hypertrophy of beta cells of pancreas to produce hyperinsulinemia, which may act as somatic growth in fetus. So it causes macrosomia. And also
so increased insulin, as well as there is a increased in insulin like growth factors. So these causes increased growth. So macrosomia. Okay. What are the other problems?
macrosomia may lead to shoulder dystocia.
Yes. Very good.
And increased incidence of IUDs, abortions, stillbirth.
Why IUDs?
Okay. It is unexplained.
Why IUD? Unexplained IUD, correct. Oh, you'll not explain, unexplained. Oi. Unexplained IUD means you cannot predict those things. It is going to happen. Yes, it's going to happen. Correct. But why does it happen? You should give a reason.
Increased RDS.
Yes, why? எல்லாத்துக்கும் why கேப்பேனா?
Ma'am, surfactant production வந்து insulin வந்து decrease பண்ணும் ma'am. Decreased
Very
cortisol.
good. So increased so it will reduce your surfactant. So surfactant கம்மி ஆயிடுச்சு. So it will cause RDS. Very good. What else?
Polyhydramnios lead to preterm labor, so increased risk of RDS.
Yeah, that can also be there. Macrosomia, and one more is your poly, and your poly can also lead to preterm. அது வந்து indirect இது, but your surfactant acting on that. So even if your baby delivers term, okay, your diet prone for, okay, even if you deliver the baby nearing term or at term, your diabetics are prone to develop polyhydramnios. I'm sorry, RDS. What else?
Neonatal hypoglycemia.
Okay, why?
Because through placenta only the maternal glucose reaches the fetus, ma'am. After delivery,
so increased insulin, so this insulin will be there, there will be no supply for the fetus, so the fetus may have hypoglycemia. Okay. Where?
Because of macrosomia, there will be increased hypoxia, ma'am, because of increased skeletal growth. So this hypoxia leads to polycythemia.
Okay.
And that polycythemia leads.
See, increased insulin.
Okay.
Increased metabolism, because insulin increases the metabolism. So there will be increased oxygen consumption. So oxygen consumption increase idum. So there will be no oxygen at all. So that itself will lead to hypoxia.
Okay.
Hypoxia over the time can result in IUDs. Okay, hypoxia itself. So this chronic hypoxia, one more, what will happen when your increased hyperglycemia, this will go and occupy your HbA1c. Okay, so there will be your reduced hemoglobin for oxygen supply, for oxygen transport to the cells, because your oxygen is transported by your hemoglobin, and once your hemoglobin is occupied by sugars, it doesn't allow the hemoglobin to dissociate. So that will also give you the hypoxia. Okay, so when hypoxia is there, one point you already mentioned, hypoxia will cause increased erythropoiesis, because it needs more of your RBCs. So increased erythropoiesis, that will cause polycythemia. Polycythemia will result in hyperbilirubinemia, because this will break down after birth. So they become bilirubin, so they become hyperbilirubinemia. Rendavathu vandu, they cause, they increase the viscosity. So blood becomes thicker. Increased viscosity achuna enna agum? Thicker
thrombosis.
thrombosis vandrum. So the thrombosis can also result in your IUDs. Okay.
Okay.
And one more, this increased metabolism, increased thing can cause lactic acidosis. And this lactic acidosis can also result in IUDs.
Okay.
Okay, ba? So these are all the complications. If you remember these things, it's very good. Okay, ba? Are we clear at that? So you should understand. And what is this mechanism of fetal maternal hyperglycemia, fetal increasing insulin and causing macrosomia? What is this called?
Peterson hypothesis.
Very good. So this is called as Peterson's hypothesis. There are many people who go by names. So some people may ask, what is Peterson's hypothesis? So at that time, you should be able to tell. Maternal hyperglycemia, fetal hyperglycemia, increased insulin level resulting in macrosomia. So this is Peterson's hypothesis. Okay, ba? So
Yes.
let us clear the diagram. Okay. So what else? What else should I ask you? Okay, wait a minute. What should I ask you? Okay. So how you diagnose macrosomia? How all can you diagnose macrosomia?
On inspection, when the on palpation, the uterine height is more than the period of
gestational age. Yes.
And fetal biometry, that is abdominal circumference, is more than 35 on USD.
Yes. So on your USD, the most specific for that is your abdominal circumference. Okay. So AC is more than
35.
35. என்னாச்சு அது எதுக்கு 35?
Circumference more than 35 centimeters.
No, it's more than 95th centile.
Okay.
For that period of gestational age. அப்படின்னா இப்ப உன்னோட கேஸ்க்கு 32 வீக்ஸ்க்கு when the difference of more than 3 weeks, then you will think of I mean like macrosomia அப்படின்னு சொன்னேன்னா then it will be 35. அந்த மாதிரி சொன்னாதா, because you cannot clearly give 1 centimeter and say இந்த சென்டிமீட்டர் மேலலாம் macrosomia சொல்ல முடியாது இல்லையா? So that you should know. Okay, so you should all remember abdominal circumference is the one of the important biometry to see that. Okay, so if you say about congenital anomalies, okay, what is the, in which type of diabetes you will have congenital anomalies?
Overt diabetes.
Yes, so overt or your type 1 or type 2 diabetes, which is your pre-gestational diabetes. So anyway, so it is not common with your GDM. So please understand congenital anomalies. Whenever you're talking about congenital anomalies, it is always your pre-gestational diabetes. Okay, so what are all the congenital anomalies? What is most common?
Cardiac anomalies.
Very good. Cardiac is most common. Okay, and what is most specific to diabetes?
Caudal regression syndrome or sacral.
Excellent. Caudal regression is more specific. Okay, or your sacral agenesis. But if people ask you what is the most common, it is cardiac anomalies. So what are all the cardiac anomalies that can happen?
Transposition of great arteries, ventricular septal defect,
and atrial septal defect. So these are all the common things, but most sorry. So the most specific for diabetes is your sacral agenesis or your caudal regression syndrome. Okay, so fine. So which level of frequency we will say that's the cutoff for congenital anomalies very high?
More than 9.5.
Yes, some people say 10, more than 9.5. Okay, some people even say 8, but okay. Say first trimester, this patient has come to you, say around 10 weeks. Okay, she has brought a HbA1c which says the result of 10%. What are you going to do? So this patient visits you in the first trimester, maybe around 8 weeks, 9 weeks. She has brought you a HbA1c report which is 10%.
Okay.
What are you going to do?
Second trimester anomaly scan.
She's pregnant.
anomaly scan or
நல்லது, நீ
target
செகண்ட்
scan.
ட்ரைமெஸ்டர் வரைக்கும் அப்படியே போன்னு சொல்லுவியா? ஏதாவது சொல்லணும்ல அதுட்ட. அது சொல்லுது முடியாது முடியாது முடியாது, நீ எனக்கு வந்து அபார்ட் பண்ணி விடு அப்படின்னு. இல்ல டாக்டர் ரொம்ப அனாமலி வருமா, என்ன அபார்ட் பண்ணி விட்டுருங்க அப்படின்னு என்ன சொல்லுவீங்க? What would you tell these patients?
Abortion
How
பண்ணலாம்.
will you counsel? பண்ணுவியா மாட்டியா?
நம்ம
ஏன் பண்ணும் ஏன் பண்ணக்கூடாது? Okay, let us keep it simple. The chances of anomaly, okay, when your HbA1c is very high, you know what is the anomaly percentage? It ranges between 25 to 30% roughly, or say it around 25. Okay, that means 75% of the time the baby can be normal. Okay, so though 25 is a big number, you still have a higher number chance that the baby can be normal. And we also have facilities to monitor anomalies for this patient. So you will not do MTP, you will counsel her that we can do anomaly scans, and before that itself, during NT scan itself, you can pick up certain anomalies. Now tell me, what are all the anomalies you can pick up during NT scan?
Down syndrome.
Yes, related to diabetes. Neural tube defect, you can pick it up, illaya? All your anencephaly and other things, you can even pick it up during your first trimester itself, NT-liye. Then when it comes to second trimester, most of your anomalies can be picked up. Okay, you tell me, what are all the anomalies that can be picked up?
Cardiac anomalies by echo.
Yes, cardiac anomalies. So how do we pick up cardiac anomalies? By your fetal echo. Okay, you can see all your TGA, VSD, ASD, LMA can be picked up. ASD, if it's very small, it's difficult. Otherwise, these two can be picked up. Okay, and all your sacral agenesis, everything can be picked up. So you will counsel the patient that we have facilities to do these things. And even in spite of that, then there is an anomaly, then we will terminate. So it is not necessary to compulsorily terminate. So that is about counseling. Okay, ba, first trimester, you know that the patient is there, and then you will give things to reduce the sugar. She's come with the HbA1c of 10% la. Poi vama direct second trimester la vana matta complication vandeko. So you will reduce you will give treatment to reduce the sugars, but you will counsel her that it can be all right, you can go on abdina. Okay, ma'am. Okay. So what is the complication of macrosomia?
Shoulder dystocia on vaginal delivery if it is allowed.
Yeah. Okay. What is shoulder dystocia?
Delay in delivery of the shoulder after for more than 1 minute after the delivery of the fetal head.
Okay. So more than 1 minute you take time to deliver the shoulder after the delivery of fetal head. How will you diagnose shoulder dystocia?
There will be turtle sign.
Okay. What is turtle sign?
The fetal head will move towards the perineum because the shoulder cannot come out.
Okay.
It's like,
see, usually your thighs will be here, your mons. Okay. So this is your vagina, which is dilated, and over here your fetal head is come out. Okay. So have you seen your turtle? இப்படி இருக்கும், அந்த பாடி அங்க உள்ள உட்கார்ந்துட்டு இருக்கும், தலை மட்டும் அப்படியே கீழே குடிஞ்ச மாதிரி இருக்கும். So this is your turtle sign, where your fetus oda head வந்து will be flushed and there will be no restitution. It will not turn to the side and it will be just like that staying there. So that is your fetal turtle sign. Okay, next time I will bring you the images. Okay, so imagine this baby is a big baby, macrosomic baby, and there is a fetal turtle sign. What are you going to do?
You want to manage by shoulder dystocia drill.
Yes, manage.
First we want to call help from assistants and the pediatrician anesthetist because we cannot manage.
Okay, so you're going to call for help. So call for help, who all will you call?
Anesthetist.
Okay, first anesthetist. நம்ம ஆளுங்களை கூப்பிடணும். Senior obstetrician. Okay. And then you call your pediatrician, anesthetist, and even your senior staff nurse to arrange. In the drug எங்க இருக்கு, அங்க drug இருக்கு, நம்ம ஓட முடியாது. So they will take and give you. So those two all people you will call. So call for helper. Then you will do what?
Episiotomy.
Yes, evaluate episiotomy. So if you're not always already given, you will give episiotomy. If you have already given the episiotomy, then you will try to extend the episiotomy. Okay, aprom?
McRoberts maneuver, ma'am.
What is McRoberts?
I want to flex the leg against the abdomen and you want to abduct so that the perineal area become extended.
Okay, so you flex and abduct the leg over the maternal abdomen so that your curve of the sacrum becomes more spacious and there's space for the head to deliver. Along with McRoberts, what do you do?
The suprapubic pressure should be.
Suprapubic pressure. So you ask your assistant to give a suprapubic pressure. So somebody pushes, suppose if this is the back of the baby and this is the leg. So somebody pushes the baby from here with the knuckle towards the midline so that the baby is becoming in a more oblique diameter and it is delivered. Okay. And if it all fails, then you have other rotational maneuvers that is not needed for your level. At least you should know. You call for help, episiotomy, and you always manage an IV line. You may make sure, because there's a chance of PPH for this patient. So
Okay.
you make sure that blood is available. You give already rush of fluid so that you're not already dehydrated. She doesn't go in shock. So all those things, general thing also you will manage. Then only episiotomy, McRoberts வரைக்கும் நீங்க சொன்னீங்கனாலே போதும். அதுக்கு மேல for your level they will not ask.
Okay.
Okay, ma. So adu mattum panikkanum. Okay. So fine. So when so what are all the scans you will do for a patient who is already diabetic?
Dating scan.
First is dating, because if you have macrosomia, you should know whether it is like, it's gone big, or is it like, வேற ப்ராப்ளமா அப்படின்னு பாக்குறதுக்காக you should know about dating. Then it is your NT. Then you want an anomaly. வேற
Echo, fetal echo.
Yes, fetal echo. When is fetal echo usually done?
20 to 24 weeks.
Yes, 22 to 24. That is the ideal time. Then you will go for your growth scans. So when you have, like a doubt, every 3 to 4 weeks, you will do a growth scan. Okay. Is Doppler useful in diabetes?
Mama, if she is over diabetic, there is chance of diabetic vasculopathy.
Excellent. So only in overt diabetes where you have vasculopathy, there is a role of Doppler. Okay. Why? This IUD which is happening in your GDM is not because of vasculopathy.
Okay.
This IUD is because of metabolic problem. Okay. Because of hyperglycemia, there is lactic acidosis, and this hypoxia leading to IUD. So your Doppler is not going to tell. Only if some vessel is involved, your Doppler is going to tell. Here, no vessel, it is metabolic complications. So Doppler has no role in diabetes. So that's why the IUDs are unexplained. So even with monitoring, even if you do Doppler, the patient can go in for IUD if the sugars are not in control. Okay. So now at 32 weeks, your patient is come with the sugar, postprandial sugar of 190. What do you want to do for her?
Mama, we want to do investigations.
Okay. What all you want to investigate?
Urine sugars, urine culture and sensitivity.
Okay. Yes.
Urine albumin.
Okay.
And blood sugars should be done.
Okay. So fine. So blood sugar you have done. Your patient is having a fasting blood sugar of 130, a postprandial blood sugar of 210. What are you going to do?
Mama, we want to give insulin for her.
Yes. So when your sugars are more than 200, we always prefer insulin. Okay. So if your patient has a fasting of 120 and a postprandial of say around 160 or 110 and 160, what do you want to do for her?
If she comes early in pregnancy, we can go for meal plan and exercise, ma'am.
So what is called?
Hello, ma'am.
What is the meal? Can you hear me?
Yes, ma'am.
Yes. Meal plan called. What is medical
Medical
nutritional
nutrition
therapy?
therapy.
What is this?
Ma'am, we want to split the breakfast into 2 equal half, which should be confirmed in 2 halves for the patient, ma'am.
Okay.
And then we want to avoid the sugars and potatoes, beetroots.
Okay. So
High.
you're going to tell the patient how all to eat. Okay. So one is the plate method. Okay.
Okay.
So plate method will be 1/2 and quarters. Okay. So 1/2 will be veggies and proteins, and it will be 1/4 will be carbs. So that is how is the plate method work. Okay. And in the veggies, you can again make it as salad and cooked veggies. So this is your plate method, which is easy to explain to the patient. So her diet should be like this. Okay. You are not supposed to restrict too much of carbohydrates. Why?
There is decreased glucose to mother.
Yes. Okay. Usually the glucose which is available in the mother, okay, reaches the fetus.
Yes.
And what does the mother utilize?
Fatty acids.
Fatty acids. So the mother utilizes fat. So they become ketones are used for the mother's nutrition.
Yes.
And all the glucose reaches the fetus. So if you reduce too much of carbs in the diet, there will be a fetal growth restriction in a diabetic mother, because the fetus is not going to get nutrition.
Yes.
So you're not going to go and restrict too many carbohydrates. Okay. According to the American College, they say 40 to 45% of your dietary carbs. And according to the other guidelines, they say 55% of the diet should be carbs. Okay. But you will modify these carbs into complex. So how can you modify these carbs to become a complex carbs? How does it become complex? What is simple sugars and what is complex?
Monosaccharide.
Okay. So let us make it very simple. Advertisements and the banga, something which we say very healthy abdina. When your carbs becomes very healthy, you make it, you add millets or multigrains. It makes your carbs a little complex. Okay. Yes.
Okay.
You add fiber to the diet, it again becomes complex. Okay. So
Okay.
either you add fiber through vegetables or through millets. So when you add fiber, you make the complex carbs into complex. So your plain rice will be simple carbs. Okay. Whereas your brown rice will be complex. So these are the things. Split it up as easy language, and you tell them to avoid food with high glycemic index. Okay. So all your roots, your tubers, they will all be high glycemic index. And fruits, if juices are there, they are high. And if they eat it as whole fruit, then the fiber content is more. So then they again become complex carbs. Okay, so these are the things you should at least know. And only 300 extra calories for pregnancy, not too much of calories. So that should be there. Okay. And medical nutritional therapy is diet along with
exercise.
Excellent. So what are you going to tell about exercise?
Walking for 20 to 30 minutes.
Okay. So walking depending on her level of activity. If your patient is already active, then you can say 30 or 45 minutes she can walk. If your patient has already been very sedentary, then you say start at 15 minutes, then you increase your pace to become 30 to 40 minutes. Okay, so that is what you are going to tell. So your medical nutritional therapy is both. It includes diet plus exercise. Okay. So you can even imagine your patient. She has a risk for preterm labor. So we have advised bed rest. So now she says, how can I do exercises, doctor? What will you tell her? What will you tell her?
Kegel's exercise.
Kegel's exercise for the mother. Sugar ka. She can do hand exercises.
Okay.
She can still sit. She can do hand exercises. Okay. So now she's come. You're given her insulin. So what type of insulin can you give?
Intermediate plus short acting insulin.
Yes. What is the advantage of giving a intermediate plus short acting over giving her only short?
Insulin is given before breakfast, so it can. If it is short acting, it TF is less, so it acts very quickly.
Yes. So when you give, very good. So when you give an intermediate, you can decrease the frequency. Okay. You can give it as morning and a night dose. When you give a combination of 70-30. So in that 70 will be intermediate, 30 will be short acting. You can even give it as BD dosing. Okay. But if you give it as rapid, it should be every meal. So it will be more dosing, and you will also need an intermediate in the night time. So that is the advantage of that. And this intermediate and short, so the short acting will have a immediate rise, so that will give you, like, immediate hyperglycemia. The short acting will take care, and the later peak will be taken care by the intermediate. Similarly, in the night dose, the short acting and the later peak will also be taken care. So this is the advantage of giving you a intermediate acting your insulin, which is your 70-30 combination is what we usually prefer. Okay. So you have given insulin, your patient is under control. Okay. And now that you are checking her sugars. Okay. So how do you want? How often you will check? What type of checking do we recommend now?
Once in 2
Blood
weeks.
sugars are, capillary sugars are.
Venous blood.
Yes, no. We are nowadays recommending capillary patient self-monitoring. Okay, she need not go to the lab.
Okay.
So this is, by compliance, this is better. So that the patient can do a capillary sugars, and it is like, self-monitoring. So it's more motivating for her to do it herself. So how many times should she do? Ideal is 7 times. Okay. But at least we stick on to 4 times a day. Okay. So 7 will be a fasting, pre-post breakfast, pre-post lunch, and pre-post dinner. So 1, 2, 2, 700. Yeah. So it will be 7 times. Okay. If it is 4, it will be fasting, post breakfast, post lunch, post dinner. Okay. So either you do 7 times or you at least do 4 times. So this is how we monitor. We monitor self-monitoring because the compliance is better. Okay, ma, fine. So now again, the target is no different. Fasting should be less than 95 and postprandial should. Okay. So now tell me, if your patient is okay, having a fasting of 130, but the postprandial is still ranges between 120 to 130. What do you want to do?
It may be due to early morning rise of insulin.
Yes. So how will you test that?
Ma'am, at 2,
So what
at
are
3
the 2
a.m.
phenomenons which you should know?
Ma'am, Samayogi's effect and dawn
So there
phenomenon.
Yes. One is Samayogi and the other one is dawn. So what is Samayogi and what is dawns?
Samayogi's is due to overdosage of insulin, ma'am, which may which may cause hypoglycemia, ma'am, which in turn stimulate glycogen
What
hormone.
happens is that in the night, you give increased dosage of insulin. Okay, wow. So what happens? Your patient goes in for hypoglycemia. Okay, that will not happen immediately.
Hello, ma'am. Hello, ma'am.
Once there is an increased insulin, that causes
Ma'am, your voice is breaking, ma'am.
Can you hear me now?
Yes, ma'am.
Yes, ma'am.
Okay, ஒரே நிமிஷம். I'll just put my phone in it. It's just disturbing. Just give me a second.
Okay.
Treatment. So macrosomia கூடவே அதுவும் வரலாம். Then they can ask you cesarean. What are all the difficulties to be seen in cesarean? And then you should also remember about antibiotic coverage, postpartum infections and all those things you should also remember. And generally for UTI also you should know. So I think I've almost covered everything which is needed in Nanikra. So if it is okay, then we will call it for today's we will leave. Is there anything else if you want to tell? We will discuss. Okay. Next class you tell me what we want. Maybe you can message to the your in charge person so that we can take that. Okay.
Okay, ma'am.
Okay, guys.
Thank you.
Okay, ma'am.
Thank you so much,
Thank you,
ma'am.
ma'am.